Are you a healthcare professional working with breastfeeding infants? Wish you knew more about assessing and treating tongue ties? Earn continuing education credits and transform your practice with the Professional's Guide to Tongue Tie in the Breastfeeding Infant. It's perfect for any practitioner who works with infants and their mothers, especially those working through feeding challenges. Learn to identify who needs treatment, build a qualified care team, and provide holistic care options. Discover the ins and outs of frenotomy, including procedure preparation and best aftercare practices. By the end, you'll be confidently supporting breastfeeding families armed with the latest protocols and be part of an interdisciplinary community of experts just like you. Tongue ties are nothing new, but the right way to assess and treat them is. Ready to make a real difference? Join now and become a tongue tie expert. Sign up today at tonguetieexperts.net/professional and become the evidence-based resource that your community needs. To show my gratitude, I'm offering you a special discount as a podcast listener. Use code PODCAST40 to save 40% off today. You're listening to the Tongue Tie Experts podcast, a weekly program providing information and support for those families impacted by tongue and lip tie and the professionals caring for them. I'm Lisa Paladino, a midwife and a lactation consultant with over 30 years of experience. If you are a parent looking for answers or a professional who is curious to learn more than what you learned in school on this topic, welcome. This podcast is for you. A gentle disclaimer. Please do not consider anything discussed on this podcast by myself or any guest of the podcast to be medical advice. The information is provided for educational purposes only and does not take the place of your own medical or lactation provider. Thank you. Hi, and welcome back to the Tongue Tie Experts podcast. I'm your host, Lisa Paladino, and today I am joined by Rachel Best and Jamie Smith, two leading experts in pediatric therapy and infant feeding. Rachel is the founder and clinical director of Small Steps Therapy, where she has built a multidisciplinary, multi-specialty practice that provides comprehensive whole-body care for families. As a speech-language pathologist, certified orofacial myologist, and IBCLC, she is one of the few clinicians worldwide to hold all three credentials. That's so impressive. With 17 years of experience, Jamie is the director of occupational therapy at Small Steps Therapy and one of Rhode Island's few AOTA board-certified pediatric specialists. With over a decade of experience, she specializes in infant feeding, development, and torticollis management, emphasizing the connection between tongue tie, body function, and feeding success. Together, Rachel and Jamie are passionate about advancing pediatric therapy, supporting families, public speaking, and mentoring professionals. Welcome, Rachel and Jamie. How are you today?
Fabulous. Thank you for having us, Lisa.
Thank you, Lisa.
That was quite an introduction and very impressive credentials that you both have, and you've both accomplished so much. And, we've run into each other a couple of times in person, and it's always fascinating for me to hear about all the things you're involved in, because your in-person practice is a large practice, right?
Yeah, we have 6 clinics in Massachusetts and Rhode Island, and we do a lot online as well. So we're busy treating clinicians most of the time.
Yes, that's fantastic. And yet you have time to research and teach and travel for lectures and research, which is what I want to talk about.
Sleep is overrated.
Sleep is overrated, but that's part of what we do,
We're
right?
kind of tired of the conversation of there's no research out there. I know we all see the outcomes and commonalities in our practice every day. So we just sort of felt like it was about time that we start to dig into that and get the rest of the world on board.
Yeah, I know. When I hear there's no research, I get like a little bit. New York in me wants to say pissed off. Excuse my language. I get pissed off when people say there's no research, because there is research. There's lots of research. There's just not research in every discipline for that discipline. Like, in other words, maybe ENTs don't have enough ENT research or whatever. I won't get into that. But we have research. So at the last conference we were at together, American Laser Study Club, the both of you together presented a project that you've been working on that was near and dear to my heart, all about the timing of infant tongue tie release. So that's what I'd really love to talk about today, because I know we could talk about so many things, but this to me was fascinating because it's starting to prove or demonstrate, at least, what I see in my own practice, and I know other lactation consultants all over the country, at least, see in their practice, that this is something that needs careful timing.
And it's a question that gets asked of us frequently. You know, the dentist and the other release providers that we work with here in New England are always asking us, how do I know? How do I know? How do I know? And, you know, we have thousands of babies that we've treated over the last 6 years. So we have the reflective data to analyze and assess. So that's what we did. You know, we were ready to answer that question with some objective information. And yeah.
So this was a retroactive study. What's the actual? Is that the right terminology of it? Like, you looked back.
Yeah.
Retrospective. Good thing I'm not a researcher. Retrospective study, meaning it looked back on data that you had already collected.
Yeah. So we were really asking the question, if an infant less than 12 months of age participates in pre-frenectomy therapy, they'll have a shorter duration of treatment overall. Yeah. So the timing, what is the optimal timing of a release, is what we were analyzing.
And the, I guess the outcome is better feeding or just shorter length of treatment for this particular part of the study?
I think that's a great question. Initially, our thought was it would be shorter treatment. And that's not what we found, but we did find a lot more information when we looked at outcomes. And that was kind of where the gem of the study was.
So I think in any good research, if it makes us ask more questions,
yes,
that's what it's for, right?
Yes.
That's how we learn, right?
Yeah, because our original question, I don't think, was the right question. That was what we what we came to find out once we started analyzing our data is, you know, the duration of treatment wasn't necessarily the important factor. It was actually outcomes. How many of these families met their goals? And all of our families that we studied that met all of their goals, both the family goals and the goals that we wrote as clinicians, had participated in pre-frenectomy therapy. So if we wanted to see who didn't meet all of their goals, it was all children who had not participated in pre-frenectomy therapy.
Wow. So just to define what therapy you are particularly talking about, it's oral motor therapy?
We would say whole body. So our team specifically is speech language pathology, occupational therapy. We have a registered dietitian and lactation. So we do an evaluation in person with all of the disciplines present, and then we kind of break out from there and provide treatment. Sometimes it's all the disciplines together. Sometimes it's just one-on-one. So it's really based on what that baby needs. You know, pre-frenectomy would like to be all of us together treating that baby, but sometimes it is one discipline.
Right. That's an ideal model and such an individualized approach. This is the second conversation I had today about how we need to keep in mind individualizing approach, even as we are looking for standardizing what we do, right? We have to be careful not to say, we're going to find this one way to do this, because there won't be a one way to do this.
Or 6 weeks of therapy. You have to have 6 weeks of therapy. That's not the answer.
I had a great conversation with one of the dentists who attended the American Laser Study Club conference, and she brought up the point of, working with families who have different socioeconomic statuses and fewer resources available. And we can know that a certain treatment approach is optimal, ideal, but that doesn't mean it's accessible for everybody. So to your point, Lisa, we do have to be able to be flexible and prioritize, in this unique circumstance, what is going to work best for this family.
Yeah, that's a perfect way to look at it, and something that, more people don't have the economic means to do this than do, right? And from what I've seen in my own experience, and I've been doing this work for a really long time, it seems like there's more oral dysfunction in families that may not be in a better socioeconomic class. And that I don't mean that as a stereotype. It's just what I've seen. More people need help that don't have the means to get it. And I had a discussion with a dentist there too, who is actually local to me. And we were trying to figure out how we could possibly maybe get grants for a clinic for the large population of, especially we have a very large immigrant population that are probably underinsured and certainly not paying out of pocket but we run that kind of, we want to help, but we have to have value for our time as well. So that's
something that Rachel and I have been talking about a lot recently too, just with the climate that we're in and decisions being made in terms of health insurance that are naturally going to impact accessibility, and trying to find that middle ground of exactly that. How do we keep it sustainable for ourselves as humans and professionals, but also not gatekeeping a service that's valuable to so many different families? Because a lot of the people who do what we do are private pay. There are so few who accept insurance. And a lot of the ones who do will do a super bill. They won't even necessarily directly bill.
Yeah. Yeah, that's where I am in my clinical practice now, because unless you have a large practice and you have somebody billing for you, it's very difficult. And I just don't have the volume, and I don't want to have the volume for that. And it just got too crazy with all the insurances and chasing after the money. It's a lot for those of us with small,
and it's
practices.
So different state by state too, which I think has been one of the more shocking things for me in, learning Rachel's side of things is, holy cow, there's a lot of variability and all different hoops to jump through.
Yeah, but we'll figure it out. And more people are getting help. And I feel like as the consumer-driven awareness rises, there'll be more ways to do this affordably for more people. A group that, I have a team in person. We don't work in the same office, but we refer back and forth to each other. And it's an OT who does CST, an SLP who does CST, a dentist, 2 dentists actually, and myself, who refer back and forth. And we were trying to figure out a way to collaborate and all get paid, because we can't expect the parent to pay all of us just because we're all in the room. It's crazy. It's difficult, but we'll figure it out.
Yeah, that's why we find taking insurance for so long, because it really is our heart to help as many people as we can, and we take Medicaid and
that's fantastic.
State insurance, because we really don't want to try to limit. We want as many people to access our services as possible, but it's a tricky game that we play with insurance around here.
Yeah. So the study that you are, I say it's in process, right? You did a little bit, presented a little bit, but
the pilot.
Yeah, you did the pilot. So that study to me is good to kind of put something tangible on the fact that we say, oh, you shouldn't just do this release without therapy. But up until now, I don't think anybody's ever shown that it makes a difference in goals. So that's fantastic, because just this week in my own practice, in that little group that I was talking about, we had a different dentist call the OT and say, I did a release on a baby because it was a severe tie to the tongue, to the tip of the tongue, and the baby needs therapy. Goes to the therapist. The therapist is like, this kid, first of all, still has a restriction, and she wished that it hadn't been done. And we can feel this in our gut, but it's hard to say why, right? And this baby wasn't doing so much better than it had been before. So now the onus is on her to call the dentist and explain that even though she thought she was doing the right thing and trying to save the family money is honestly what she was doing, because she takes insurance, but the therapist doesn't. She really didn't help. She really, even though she thought she was helping, she didn't help. And that puts us in a awkward situation.
We had a very similar baby last week, and it's tricky too, because I think once the parent's been through that journey where they've had the release and it hasn't helped, and they're seeing another provider who's telling them all these ways that it's not helping, it can get harder to have the parents buy in, right? So they thought that they were doing this one thing, the release, and baby was going to feed. And now we're telling them they need this additional piece. And I think it can be more of an uphill battle at that point.
Yeah. Yeah. So that's the place we're at. And she wants to come to me now, and we're trying to figure out how to arrange, it's just, but this situation happens over and over and over again in my practice. And I'm sure in practices all over the country, that the well-meaning provider who does the release without any therapy, even if they know about therapy, that was the frustrating part. It's like,
Well, that was what prompted us. We had a very similar call like this with two of our local dentists who are excellent providers. And the question that they really wanted us to answer is, how do we know when to release those very little infants who are really struggling and have a really obvious anterior tie, and that mom is in excruciating pain? How do we know when and what? So that was a conversation we had too. Sometimes there are those exceptions to the rules where we can do a release. And I'd like to continue the communication with these providers too. Like, sometimes certain infants are going to need a multi-phase release, especially those anterior ones. And we had a baby a couple of years ago with Dr. Kaplan, who is a local dentist south of Boston. And we went in with the plan of he was going to release in phases. And, this is a baby we presented on multiple times because it was such an extensive case. But the family was so on board with the whole process because we had upfront conversation and collaboration. And I was actually able to witness and observe that the second release that they had. It was just an excellent whole collaborative process. And we had all of the disciplines involved. And that one has always stuck out in my head too. Like, sometimes, yes, we might need to do a release right away, but can we talk to that family and prepare them of, okay, you might need a second release. We might need to do, once Jamie gets in there and does her CFT and releases some of that neck tension, and once I get in there and get that tongue moving, the tissues are going to look a little bit different, and you might be able to get a much deeper view of that frenulum, and you might need a second release. So, all of these pieces need to come together. And I think good communication with the family is the game changer.
I love that the communication is key, and letting parents make informed decisions, because ultimately they want what's best for their baby, and they know in their heart, in their gut, in their soul, what should be done for their baby. And they have every right to say, you know what, I want this, even though I know it might not be the be all and end all. They have the right to do that. And I agree with those early releases. We used to want every baby to get released in the hospital. And now I'm like, no, wait, exactly. Right.
And I think that's another place.
Because we learn, right? Because I saw all those quick releases not be successful. I have this theory that because a baby, as a midwife, I know they're literally in the fetal position, all curled up and tight and not even opened up enough to know where that frenum is going to wind up, right?
Yeah, I really loved at the American Laser Study Club. There was so much conversation about that. I think that we, as an area of specialty, are starting to consider that the tissue is constantly changing and realize how that can influence a release and the outcomes. So the conversations are really shifting and expanding, which I think is really great. And I think that's one of the things that research helps us do is we can start to answer a question and move on from that. If we don't have to be stuck in this defensive stage of defending why we know that this is helpful, then we can move on and identify all these new questions we weren't even thinking about.
Mm-hmm. Yeah, I mean, it's beautiful when we have these multidisciplinary open conversations. And I love being in the room with so many people that are willing to collaborate and willing to learn together and teach each other. It's just a beautiful experience. Do you want to hear an example of how tissue changes over time? This is, I'm always talking about my grandson for one reason or another, but this was an interesting thing. When he was born, he was one of those babies that we knew we couldn't wait too long because of the pain he was causing. So we did some therapies right away. I mean, he saw a chiropractor and an SLP and, whatever I was doing with him. But still was released at 2 weeks. But we knew that and his mom decided, whatever it's got to be, let's try it. At that time, there was no cheek restrictions. There was no buccal ties. He was totally clear of that. So we did the lip and the tongue. When he was over a year old and it was time to have his tongue tie released again, he had a buccal tension on one side. There was a complete frenum on one side that was not there at birth.
Oh, interesting.
Isn't that interesting? And he had a lot of different therapies. Like, he had everything you can have. Like, all my friends worked on him.
Yeah.
Like, we were like, let's try the osteo. Let's try the PT. Let's try the OT. Let's do some tummy time. My poor daughter was going from place to place to place. And here we are with this child who had one buccal frenum that needed to be released that wasn't there previously.
I think one of the things that's really interesting about watching that tissue change too was one of the really unexpected outcomes we found in our research, that like a third of our participants didn't even need a release ultimately because they met their goals based on therapy. And honestly, I thought that number would have been a lot smaller. I mean, if you don't stop and look at it, you really don't realize those trends and patterns. And that was pretty cool.
Have you ever wished you could help that mom who is questioning if she has enough milk? Ever wanted to either reassure her or know when to refer? As a lactation consultant, I created the program Understanding Milk Supply for medical and birth professionals to help you to feel more confident in those exact situations. This affordable, recorded video mini course is open to anyone who works with pregnant or breastfeeding families. It's a particularly valuable opportunity if you're an SLP or an OT who wants to gain an understanding of how breast milk is made, or a dentist in the field who is often the first-line provider for tongue-tie treatment. The function of the infant at the breast depends on milk supply. Even if care of the mom isn't in your scope, there are basic principles that you can learn that may rescue a family's feeding goals. In Understanding Milk Supply, I teach you what red flags to look for, when to refer, who to refer to, and how to advise the family in the meantime. And there's one LSERP included for lactation professionals. Go to www.tonguetieexperts.net/milk-supply. The link is clickable in the show notes. And as always, you can use coupon code PODCAST15 to save 15% off this and all Tongue Tie Experts courses. Thanks so much.
Cool.
That is cool. And I'd love to follow those people and see how they do going forward, if that's true function, or are they compensating in some way, right? Like, that would be really interesting
which is one cool thing about being such a large practice is if that family does seek treatment down the road, the likelihood that they email us, hey, now Johnny is starting solids or not speaking, or we're noticing this developmental delay, so they often will come back to us because they had a positive experience to begin with. So we get to see them later down the road. But yeah, good ideas for future study.
Definitely.
Yeah. So it's safe to say then to a family, like I've been saying for years, let's do the therapy first to make sure that the tongue tie is actually causing the problem.
Exactly.
The frenum is that tight that it actually needs a procedure.
Yeah.
We can't tell that unless we've had therapies or done other things. And then on the lactation side of things, there's always things to work out as well on the maternal side. You guys are mostly talking about the baby therapy, right? But on the lactation side, maybe it's milk supply, maybe it's a maternal something or other going on, right?
Yeah, making sure the pump is working if the parent goes back to work, and
right.
There's a lot of pieces. And I like to, if we do discharge an infant without a frenectomy or some sort of release procedure, kind of giving that parent a list of things to look out for. So, if your baby starts breathing with their mouth open, if you're not seeing a lot of tongue movement when they're eating solids and purees, if they're not sleeping well, if they don't develop these signs, like a nice milestone chart that here are red flags or yellow flags that to look out for. And then, just send me an email and we'll get you back in, or we'll give you some suggestions to problem solve. And, because things can look one way at one point in time if we're discharging at 7 months, but then at 15 months, it might be a completely different scenario.
Yeah, absolutely.
And I think that loops back to what you were saying.
Let's just go back to that. You said open mouth posture. I never want to miss an opportunity in case nobody's heard this before.
Yes.
Let's talk about why open mouth posture in an infant isn't that cute. Right? So do you have people in your social media feeds, like posting pictures of their babies, and you're looking at them going, oh no.
Well, I can think of one mutual friend with Jamie and I who mom posted a picture of the baby sleeping in the car with the mouth wide open, and she was like, oh, he sleeps just like his mama. And I was like, oh.
So let's talk a little bit about that. Why is that a red flag?
Those babies who snore, and parents often think, oh, it's so cute, listen to them snoring, and maybe cute, but not ideal.
Yeah.
So the tongue, we talk a lot about this, is the epicenter of development. So, if that tongue is low in the mouth and it's not activating that palate, it's definitely going to impact, the growth of the face and those craniofacial structures. And also it's really important for that tongue to rest on that palate. This is the palate. I'm using my hands to demonstrate the tongue and the palate. You're innervating cranial nerve 5, which releases serotonin, dopamine, and norepinephrine, and also helps you enter into that rest and digest state. And Jamie then talks a lot about innervation of cranial nerve 10, the vagus nerve. So all of these pieces together, we're helping that oral facial development, which impacts the whole entire body's development all the way down to the toes, because we're not just individual units. Every single system is connected to the other system. And also it helps us feel good and enter rest and digest. And, there's endless things that are connected to entering into that rest and digest state, but it's so important for so many reasons.
This is one of our big passion projects right now too, particularly related to colic. We've had a lot of families who've had a really challenging journey with colic. They've gone to a local colic clinic, and the conversation has been, in the parents' perspective, a little bit, shallow,
There's actually a colic
clinic. But a lot of the treatment, so to speak, is, baby needs to sleep more. Yeah, that'd be great. The family would love that. How do they make that happen?
Yeah. Colic is a symptom.
Well, that's exactly it.
It's not a diagnosis. It's a symptom.
Yeah, I was doing research for another presentation I was doing this morning, actually, and looking up the definition of colic. And one of them is when an otherwise healthy baby cries excessively for no obvious reason. And I wanted to pull my hair out because it's not for no obvious reason. And why do we accept that as a definition? That's ludicrous to me. Families are stressed to the max. My younger brother, I'm 11 years older than him, he had colic, and I can tell you it was so stressful for the family, and to essentially be shrugged off. But all of it.
Right. So I had colic, right? My mom used to talk about how I would scream and scream and scream and then projectile vomit, right?
Yeah.
Fast forward 45 years later, I found out that I'm allergic to milk, right? And I was given full milk protein formula and then weaned off to whole milk at 3 months old.
Wow.
It was like, are you kidding me? But nobody knew to think what that, and back then they would just lock you in your room and close the door. So yeah, I should be in therapy for the rest of my life. But anyway, both mental, emotionally, and physically. But so at this colic clinic, did they have any actual root cause solutions or just what to do to get through it?
Here's a prescription for famotidine. See you in 3 months.
Yeah. And that's kind of our big thing is, we always say to the parent, why? Like, let's figure out why. Why is your baby crying so much? Why are they having feeding difficulties? And if we can address the why, then we're going to actually see progress and not just keep managing symptoms literally for the rest of their life. We're just going to keep slapping on Band-Aids for each new symptom that develops. But if we could get to that root cause, which, in the population we work with often is tongue tie or ankylosing. So if we can address that from the whole body perspective, then, we're seeing really amazing outcomes with our population, which is awesome.
Yeah.
The thing about that Band-Aid approach, it turns into exactly what you're saying, Lisa. It's whack-a-mole with symptoms. Those don't go away. The Band-Aid doesn't cure them.
No, they didn't.
It's going to develop a compensation. It's going to persevere in another form. You're just hobbling through that day, and that's it.
We have a second presentation that we presented at the New York State Conference last year, and I think we presented it at ASHA as well, which is the American Speech and Language Hearing Association, of our same team, Jamie, the OT, myself as speech, and Alyssa, our dietitian, of a feeding team. So, we just move ourselves up to the 2+ age group, and we're doing all the same things. But for all the kids who now have 2 to 20 years of negative associations with food, choking, I just think when Jamie and I first got together and started doing this work, she would pull up pictures and look at that child and how their whole body was tilted one way, how the way they were sitting at the table, how they're like weight bearing on their arms to like help them balance. And, Alyssa, our dietitian, talking about circles under their eyes and iron, all of these things just continue to add up, which is then we had that team first. Then our infant team was born. And, we're like, if we can get in and treat these children as infants, we can eliminate our jobs of treating them as children.
Yeah. So how do we get from mouth breathing to this? I don't know. But what I do want to, what I also want to say is about the mouth open means we're not breathing through our noses.
Exactly.
And if we're not breathing through our noses, we know what happens. I mean, that's key to good health. And somehow I've evolved my thinking to the reason we're breastfeeding is for airway. I used to think it was for nutrition, but now I know it's for airway down the road, because if we can't breastfeed, something's going on with our airway, or something will be hampered in our development of oral facial complex that will prevent us from having airway health going forward. And once you know that, you can't unknow it. You can't unsee it.
No,
you can't, I look around at people and say, oh God, I hope they're okay. Or, just by the shape of their face.
And it's so major. Having an airway disorder, sleep disordered breathing, those are not insignificant things. They are huge. They impact everything. No. You end up on all these medications because you're presenting with ADHD symptoms. You have brain fog. The list just goes on and on and on to this.
And how many kids with, behavior issues, or even diagnosed with being on the spectrum and are just not sleeping. And of course they're going to be irritable and misbehaving because they're tired.
And that's another thing I think happens often too, is once there is a label for something, once they determine, oh, this child has autism, the conversation about other things going on with them disappears. You can have a child with autism who also has a tongue tie and is mouth breathing and dealing with all of the repercussions of that. And I feel like that doesn't get talked about enough.
That's a very good point. And you're right. I haven't heard that enough, that we shouldn't just put the label on and then forget about all the other things that could be going on. Yeah.
Got a lot of work to do.
That comes from our siloed learning in medicine. We don't learn together. We learn separately, as if the body is broken up into little parts instead of one whole body.
Exactly.
Like, I always give the example of my father-in-law, who's 85 and has about 7 different doctors for the different parts of his body. You know, it's crazy.
Yeah.
It's crazy.
Yeah. So to
The
have
cardiologist,
a team
the nephrologist,
you really need a team captain, which,
Yes.
in my mind too, up there with the team captain is the quarterback, which would be the parents, trying to give them as much information and resources. And we love collaborating with other providers. If they say, oh, we're working with this IBCLC, this dentist, especially with somebody we don't have a relationship with yet, we love to make sure we can all get on the same page, which parents are always so like, oh, okay. Like, how's that connected? Like, what do we need to know? Because I had a really long conversation with the nurse at a pediatrician last Friday because I found something in a baby's mouth, or found something that was missing in a baby's mouth that was quite alarming. So to get the nurse on the phone and they're like, I guess we didn't look in the baby's mouth. Okay.
Wow. Yeah, because pediatricians don't need to examine the oral cavity?
The baby had been to the ENT and had been scoped and still was anatomy was atypical. And
yeah, I've had cleft palates missed by multiple providers on the same baby. Just crazy. Anyway, people need more time with their patients. That's number one, right?
And more willingness to collaborate. Like, we need to, that needs to be a change in the medical field, is that we sit and talk across disciplines.
And I think
that's what we loved about the study club, right? That we all came together.
I think that's funny.
Yep. And there's no hierarchy. Everybody is just as important.
That's one of the things.
And that's what I love. The acceptance between provider levels. There's no like, oh, well, you're a doctor, so you're more important than me. No, everybody's in the same room, talking the same language, learning.
That's the only way to have true meaningful collaboration too, because if you have that scaffolding where people don't feel like they're on equal footing, then you can't have true in-depth conversation. And I feel like, Rachel, that collaboration, that's the way that we can address all of these concerns without, you really can't have one person doing everything. I mean, it gets watered down. It's too many hats to wear. We don't have enough time with the client. So that's where collaboration is really key, because then it's not about my 1 hour, it's our collective 3 hours. That really makes a difference in the big picture.
Yeah. And you both have a beautiful way of collaborating together. And I'm in awe of the practice that you have set up, and your practice model is just something very admirable. And I hope that we can see more practices like this pop up all over, because it's for the best, for the outcomes.
Yeah, I think that's one of the journeys we'd like to have. We would love to collaborate with more practices nationwide and share the successes and the things that we've built and how it could be replicated. We're never going to be a nationwide practice at this stage. I don't think I have the stamina for that, but we would love to teach other or mentor other clinics as well. And like, this is how we did it. This is how we manage funding and financing and insurance, and another future goal of ours.
Yes,
and I think one of the things I realize is if you're not at least considering all of these pieces, you are missing something.
Yeah, that's a good point. Yeah, we have to consider the whole body and all the parts of the body. At least all the parts of the upper body. Let's at least not miss what's in the mouth.
Oh gosh, I know. It seems so basic, but.
So before we sign off, just I'd love to hear your thoughts on what's next for you. Do you have any conferences that you are scheduled already at, or So tell us, and where to find you. Where can people, if they want to learn from you, what's the best way to reach out? And I'll definitely put it in the show notes as well. But let me know what you want me to shout out.
One of the best ways to contact us would be email. So maybe we can pass that along to you, Lisa, for the show notes. We are presenting at AOTA in April, the American Occupational Therapy Association National Conference, which we're excited about. And I am really hoping that some next steps for us this year are creating some trainings for providers like us who are looking at how to consider more factors. For me, it's really big that the speech therapist who's doing feeding is thinking about postural stability. Does the child have the stability that they need to be able to eat safely? And I'm sure there's plenty of things the speech therapist wants the OT to know. So how can we, marry all of those things together and be the most effective clinicians we can be? And to Rachel's point, how do you take this work and replicate it in Florida or Virginia, California, anywhere that the three of us aren't, which is what we want to see continue.
That's beautiful. Rachel, any last thoughts?
Yeah, well, we're also going to continue our research. We had made some amazing connections at that conference 2 weekends ago. So we already have plans and work to collaborate with some of the great connections we made. And we're also very fortunate we have a respiratory therapist on staff. So, you were just talking about airway health and how that's so important. So because we see so many infants, she has really expressed a big desire to support our work with infants who are experiencing respiratory distress or have any airway concerns. So we are going to kind of hopefully start some research and develop some programming around her specialties as well, which is incredibly exciting.
Yes, very exciting.
Yeah.
I can't wait to see what develops.
Yeah, we have some classes. We have a couple already on our website as well, which is smallstepstherapy.com. But that's our next big thing is, for those families who aren't able to come into the clinic and maybe insurances, we know it's going to change a lot over the next few years. So if they can't afford to even use their private insurance, can they access something online to help support? Maybe not necessarily the breastfeeding piece and the early tongue tie piece, but early feeding and introducing foods. So we already have a class online.
Yeah, I just re-recorded my parents' guide to tongue tie for that very reason. And these courses have to be redone every couple of years because our practice changes, our recommendations change. And I'm very excited that I'm going to make that available because I don't think there's enough online. Like, I don't ever want to tell a parent that they should just take my course and not have in-person help. But I want to support that in-person help because maybe it's subpar help. Or maybe it's definitely not what I know. So I try to pour out what I know into my courses, which I'm sure is similar to what you're doing.
Well, on-demand is what people want right now. That's really what it's showing. Obviously our entire business is based on in-person services, but there is a huge population, I think, that is not accessing in-person services and maybe would like to have that online option first. Yeah. And then, we've been really explicit about here's what to look for. Right. Seek out a professional if you have these. So kind of here's the foundation, giving you that knowledge, and then come find us or anybody who specializes in this. And I think that's
the thing.
Yeah, and my most popular handout is questions to ask a provider.
That's exactly what I was just going to say.
Right, because I was thinking how is a parent going to know? Like, I hate the term preferred provider. That's overused and it doesn't even work anymore. So what should a provider know that's a good provider? Like, how are you going to know that person knows what they're doing? So I have a list of questions to ask. So, yeah, I mean, I love education, and that's my passion. And I think it's great to hear that you're doing that for older kids, parents of older children as well.
Yeah.
And Jamie is very good with social media. So follow us on Instagram at Baby Steps New England and Small Steps there.
I don't know if I would be very good, but I'm doing my best. I'm a millennial girl living in the Gen Z social media world. So.
Oh, gosh.
You're doing a great job. Well, thank you, ladies. Thank you so much for spending time with me today, taking time out of your very busy lives to share with us what you're doing. And I look forward to watching you grow and do more exciting things in your practice and for your patients.
Thanks so much for having us.
Thank you, Lisa.
Thank you so much for listening to this week's episode of the Tongue Tie Experts podcast. Check out the show notes for useful links about the topics we discussed and for ways to follow us on social media. Please subscribe to us on your favorite podcast app. And if you enjoyed listening, we'd love it if you'd rate, review, and share with your friends and colleagues. Thanks so much. Bye-bye. Tongue-tie cases can be confusing, but what if you had a place to ask questions, learn from experts, and connect with professionals who truly understand? That's exactly what you'll get when you join Tongue-tie Experts Insiders. It includes monthly online meetups with me, Lisa Paladino, expert guest speakers sharing the latest research and best practices, a private community of other professionals ready to support you every step of the way. For just $19.99 a month, you'll never have to navigate tongue-tie cases alone again. Join the community today. Your future self and your patients will thank you. Sign up now at tonguetieexperts.net/insiders.